is a proud moment that IAPDG is doing great, and every day we are having one or other sessions which are really praiseworthy. And for that, we will like to say thanks to our president, Dr. Neelam Mohan Madam, because her vision has brought this IAPDG, and we are able to see daily activities in one or other way, which are definitely benefiting all of our pediatricians. So with this, I wish to welcome all of you, respected President, Madam President Elect, Sir, and the mentor of teachers, none other than our Pajapati Sir. I mean, it's always a treat to listen to his wisdom pearls. And today, that's what we are going to see in our mentor mentee program, Tuesday PG Clinics. I request all members of pediatric committee to kindly join in more number and get benefited of this program. Thank you very much.
Thank you.
Over to Nehal.
Thank you. Thank you so much, Ruchira Madam, for such a wonderful welcome. As we know, the teaching is very much near to the heart of Neelam Madam, our president. She teaches in a very different ways also. So the PG teaching is again a heart of the teaching program. And for this, we have a different committee this time to cover all over the India, all the PGs, so that all the medical colleges and all the PGs can get benefited. For this far-sighted program, I welcome our Neelam Mohan Madam for her presidential address.
Thank you so much, Nehal. Indeed, a proud privilege for me to be here today to welcome all of you all towards the mission of IAP, which is to support the colleagues, the pediatricians, the youngsters, to work for child health as our main goal. And in that endeavor, where we keep doing the conferences, meetings, digital, why? The only reason we do is wisdom pearls are different with everyone. What Prajapati knows, I wouldn't know. What I know, Singarvelu won't know. What he knows, Ruchi or others may not know you. So by sharing our knowledge, by the next generation, if we people do not understand today that the next generation, which is getting AI, will find it extremely difficult to understand the concept about a case, how to evaluate, how to dissect, how to go clinically. And you yourself have realized, so a lot of efforts are being done now in the medical education thing. And that is going to be my next surprise to you all. How I wanted to make Dr. Singarvelu in charge of it. And Dr. Singarvelu right now is on a mission of traveling across the country like all of us do. And I hope he gets a little more time and we are able to focus more and more. So we wanted this PG special, which is the files from India. That was also PG, where different institutes speak. It is not going to be one. But with Prajapati, it is different. It is, like, I think when we were young, we used to hear a lot about Dr. Ambedkar. Everybody's heard about him. And we all have grown up respecting and remembering his teaching. But as they say in life, you need to train someone, you need to have a replacement so that the life should move on. And that is what I can see now in Baldevji. When I met him 25, 30 years earlier, he was totally into his own practice and a very busy practice and cases and very enthusiastic and attending the meetings and discussing a lot gastroenterology cases with me, if you may recollect, though I was very young. But what I wanted to say was, even though he was in his peak in 50s or whatever, but he had that 40s, he had that enthusiasm to know even from youngsters about the case. And then he strengthened himself so much. They say that the best way to learn is to teach. Because I was just telling to Ruchira, when I have to write one position paper, maybe I will edit it 10 times to see this line to do, because you want to be picture perfect in that when. So I guess that's how Dr. Prajapati has matured more and more and more through his teaching, because students also teach us those questions and then you develop it. And I hope that this moves on and somebody takes in the role and takes in the torch of Prajapati too, because right now he's at his peak in teaching and people should take his torch. While many students have joined, I have to request to these students, if you really care for your colleagues, don't give them gifts. If you really care, you should send them, forward them this message that there's somebody to teach. Books mein to mil jayega, but he may dissect a case which everybody may not be able to. So with those few words, I would wish all who have joined, Arif, Ibrahim, Vade, Twinkle, Ranjan, Kirti, Harvi, Purvi, Rajdeep, all of you, to send this message to various groups so that others can also able to join. And I am going to put all of this. Give me another couple of weeks. I'm working on it. All of this will be not going lost. People will be able to see it subsequently also working on those agenda. And I'm extremely grateful to my colleagues who have joined with me, Dr. Singravelu, as the president-elect. His peace, his wisdom, and his support means a lot. Dr. Ruchira, who's always there for all the meetings, joining in. All of you, and I can see Yogesh ji will stressed. Don't be stressed. All of us are doing good work, and together we will change the scenario of child health in India. Thank you so much.
Thank you. Thank you, Neelam madam, for such an encouraging and wonderful words. Thank you so much. We have one more dignitary with us, Dr. Singarvelu sir, President-elect of IAP. Sir is a hardcore teacher and he retired also from the medical college from the highest post. So I welcome Singarvelu sir and I request you to please introduce the heart of this program, our mentor convener, Dr. Baldev Prajapati sir.
Thank you, Dr. Nahal, the most respected dynamic President, Dr. Neelamagan, ably supported by our HSD Ruchira ma'am, and our past secretary Yogesh ji, and all the team who involved in the PG teaching program. Today, our national convener and teacher of teachers, my best friend Prajapati sir, doesn't need any introduction. But for the sake of newcomers, for postgraduates who have joined, who are going to be benefited, see, to get to Prajapati sir, to meet him as a teacher in Ahmedabad, how many people are longing. He is coming in the doorstep of our, and you people are sitting at our home conveniently watching this program, and thanks to Neela madam that she brought a Digi app so that you can download at any time. So really hats off to you that the madam, the person began who brought this Digi app, our Ganesh Kulkarni is there. So the introduction of our Prajapati sir, person who has been committed to teaching. See, so many teachers, other I also been teaching more than 3 decades, and but we are every day from his teaching. Everyone teachers are learning the meticulous way of concentrating the fundamentals are the great. He is not only an academician who retired from the prestigious government medical college of JLS College from Ahmedabad. After that, he is working, because even after completing his superannuation of NMC, his rich academics being attracted by other medical colleges, he is being a director and looking after in a university, such a great position. So he is not only an academician, a person who was in IAP. I think he is the longest period who was in a EB member, more than 5 times. Now the rule doesn't even permit to that because on those days he was there. So a man with academics with IAP who knows what else to know about him. People are very lucky that this program of vision of Digi Academy brought by our Neelam Mohan, and today being the first, though it is old, the timing I feel for postgraduates, it is ideal timing. So 6 o'clock, it is meant for PGs. Practitioner, whether joined or not, we are not worried. If they are interested, we want to focus for postgraduate. I think this is a good timing. I think surely only thing, Madam Nehal ma'am, is that you got a very good tempo and so many others are there. See that the message goes strongly to all people. So the postgraduates where they are teaching nowadays is getting because of so many other reasons. Definitely such a teachers are you are going to bring surely, and today is going to be a very good beginning. Surely with Prajapati sir is there his expertise, and for the past 5 years he is conducting PG clinics in our IAP. Surely with his beginning, I'm sure that he will come frequently also as an expert. He will be there, though other mentors are there. So without wasting much time, so over to Nehal ma'am. So definitely I wish both the mentor and mentee and all the participants and all the team involved in a great success, though that this program will go on in future in a very well way. Thank you, madam.
Nehal, who's presenting today?
Dr. Abhiram Prasad.
Okay, thanks. I didn't mention his name. Best wishes to you.
Thank you.
Thank you, ma'am.
Thank you, Singarvelu sir, for such a wonderful words. For the man who actually doesn't need an introduction, to introduce him is also an art. Thank you so much. Some names are worth mentioning. For this, I would like to invite Dr. Ganesh Kulkarni sir for being here as a convener of the DG team. Thank you, sir, for being here.
Thank you so much.
Another name, Dr. Professor Yogesh Parikh sir, the past HSG. He is always there whenever the PG teaching is there. And with his vision, we also have at Gujarat the E-Gurukul Pathshala. Welcome, sir. This team, the Tuesday PG Clinic team, I need to mention and I need to thank all those who are working for this team. Dr. Arif Vora, who is an assistant professor at BJMC Medical College. Dr. BJMC Ahmedabad. Dr. Purvi Patel, she is a professor and head at Pramukh Swami Medical College, Karamsad. Dr. Puvaji Vardarajan, she is a professor at ICH Chennai. Dr. Nirbhay Mehta, sir is a professor at MGM Medical College, Indore. And Dr. Trupti Joshi, associate professor at GMC Aurangabad. Welcome team, a wonderful team we have this time. I also welcome Dr. Priyanka Patel. She is an assistant professor at BJMC who mentored Dr. Abhiram Prasad, third year resident at BJMC Ahmedabad, who is going to present the case. Welcome you all, and please forgive me if I have not mentioned anyone, a teacher, a mentor. You all are welcome, and all of the students, please have a journey of learning. So now the stage is set, and Baldev sir, it's all yours.
Okay, may I request the presenter to stop sharing for a while?
Yes, sir.
Please, for few seconds, yes. Because it is my duty to acknowledge at least the inaugural function of this Tuesday PG Clinic. Respected very dynamic lady, our President, Dr. Neelam Mohan Madam, President-elect, Professor Dr. Singarvelu, I will say very young and dynamic Honorary Secretary Dr. Ruchira Gupta, Dr. Nehal, our own person, I will say helping in so many academic programs, past HSG and my friend Dr. Yogesh Parikh, again very young, dynamic, bubbling person Dr. Ganesh Kulkarni, our own people, but let me mention the name. Then Dr. Priyanka, Dr. Arif, Dr. Trupti, and so many friends, those who have, I will say, prepared this stage for this function. First, let me express a word of gratitude to Dr. Sengarvelu for his kind words of the introduction. At the same time, office bearers, our President, Dr. Nilam Madam and Dr. Ruchira, for this particularly Tuesday PG clinic, and again gave me this opportunity. So many times my friends are asking that, what is, I will say, is that still you are continuing to work, to teach particularly. Are you not tired? Or what is your interest? And always I say that I don't do anything free. I have some interest. And my interest is to learn the pediatrics. And as already our President Madam said, the best method of learning is the teaching. And absolutely right what Madam said, that while interacting with the students, I'm not sure how much I'm teaching them, but certainly I'm learning a lot. And probably in a span of even the other teacher for about 40 years, I started my journey as an assistant professor in 85. So now more than 40 years as a teacher, and probably constantly, whenever I've got the opportunity, I've not missed to interact with the students. And to be very frank, if I'm talking to the young, my friends, that really if you want to be the good academic person, naturally you have to work very hard. And the best method of learning the subject is to interact with the friends, particularly the young friends. I remember our late president, I will say the who was a person of, I will say, missile man he was studying, Dr. Abdul Kalam sir. And I remember his one sentence that if you want to contribute in this society, interact with the youngsters, particularly the teachers, whatever you want to contribute. And I'm sure that whatever I know the pediatrics, if I interact with them, may not be all, but certainly some of them will take it. And tomorrow they will be far better than what we are today. I will say with that, really this is the driving force for me to continue this activity until all of you permit, probably I will do it. Thank you very much, Madam, our President, and our Secretary, Dr. Ruchira, for particularly this program. And I'm sure Dr. Sengarvelu basically himself is a teacher, so certainly he is going to support all of us for learning and even the teaching this type of the programs. Again, thank you very much, all of you, for even beginning of this program. I will say very nice inaugural function has taken place with the presence of so many dignitaries, and certainly will continue in a, I will say, impressive fashion, which will be very fruitful to all of us, not only the students. The way in which all of you know that our main idea of conducting this clinic, as if we are discussing bedside. Of course, we are offline, but still, we are online, but still, we do in such a fashion that as if we are with the patient and interacting with the patient. So that absolutely the clinical medicine, and one thing somehow, I do believe even at present that AI or whatever the advanced technology comes, it is not going to replace this type of the bedside teaching, and should not. If probably it happens so, probably may be dangerous. Of course, it's a good technology. We'll have to learn how to utilize, probably to sharpen our, I will say, clinical skill. But at the cost of this bedside or this discussion, if you go for the advanced technology, may be dangerous. And therefore, I request my young friends that yes, you should know the technology, even be the expert in that field, but with the basics and the bedside. And then I'm sure that it will really contribute a lot in our making the clinical decision. Thank you very much again. And with this remark, probably if the, I will say, dais permits, should we start with this session, Dr. Nehal?
Yes. Yes, sir.
Okay.
Yes, sir.
Wonderful
now-
beginning, sir. Wonderful beginning, wonderful. Thank you.
Thank you, sir. Thank you. So now I request the presenter to share the screen and start the history part. And I request all the students that, as I said, please interact. Not only the presenter, everybody, whatever thing comes to your mind, you should make the comment questions. Can you make it full screen? Yes, fine. Dr.
Okay,
Abhiram,
sir.
you can start it. I will remember now your name, and you are from
Yes,
BJ Medical College. Yes.
sir. Sir, respected faculties and my dear friends. Sir, myself Abhiram Prasad. I'm a third year pediatric PG resident from BJ Medical College, Ahmedabad. Sir, I am presenting the case of a 10-year-old male child, Arshad Sipai. He is second in birth order, born of non-consanguineous marriage, belonging to lower middle class according to modified Kukusami classification. Sir, present with the chief complaints of weakness of both lower limbs with difficulty in walking for the last 2 days, change in voice and slurring of speech for 1 day, difficulty in swallowing, and nasal regurgitation of food for 1 day. Coming to history of present illness, the child was relatively asymptomatic 3 days back. Then the child developed acute onset weakness of both lower limbs, which was progressive in nature. Initially, the child complained that his footwear is getting slipped off while walking, then later developed difficulty in standing up from squatting position. That day, the child went to school, and by the evening, weakness progressed to that extent the child is unable to wear weight on his lower limbs. From the next day morning, the child was unable to get up from the bed. Child developed weakness of upper limbs on the second day, and he was unable to hold the pen while trying to write homework, but the child was able to move the upper limbs above the shoulder level. The mother noticed change in voice and slurring of speech on the second day of illness since morning. The content of the speech was appropriate, meaningful, but the mother noticed that the child is having difficulty in saying some particular words. The voice was also having a nasal tone, no history of any associated nasal block or sore throat. The child had difficulty in swallowing food from the second day of illness, mainly to liquid foods than to solid. There were 2 to 3 episodes of nasal regurgitation of liquid feeds also. Notes associated with any coughing, nausea or vomiting, pain abdomen or heartburns. Then there is no history of any fever, cough, cold, loose stools, no history of any trauma to head, spine or limbs, no history of any abnormal tightening of limbs, abnormal involuntary movements of the limbs, involuntary passage of urine or stool, no history of any altered sensorium, no history of any travel to outside regions, no history of any recent injection medication or vaccination.
Okay, can you stop sharing for a while before you go for past history?
Yes, sir. Yes, sir.
Thank you. I think let us try to think, analyze what are the information Dr. Abhiram has provided. Who will take the lead? He said that here is a 10 years old female and problem started since 3 days. Duration of the illness is 3 days. Very nicely he described the whole, I would say, sequence of the events, that how it started, what was the onset, how it progressed, and what is the present status. So who will take the lead there? How will you analyze the complaint or the symptoms? First he said difficulty in walking, and then the how it progressed. Second very important complaint is regarding the voice, and third is the difficulty in swallowing. So first I will say you can take one by one symptom. What does it indicate? And then put together what does it suggest? Who will take it? Any postgraduate student, please come on. And I think when you are discussing, don't hesitate, because I may not be knowing all these students by name, so I may not be able to call, but I hope that somebody will come forward voluntary for the discussion. How will you, I will say, analyze this difficulty in walking and then progress and even the upper limb involvement? And then what does it indicate? Anybody? Please keep your video on so that I can see the person. Yes, Abhiram. I think Abhiram, you can identify your colleagues. Your colleagues must be there so that I can call them. Please,
Sir.
you should not hesitate. They will not create the problem for you.
Sir.
That why did you name? Yes. Are there
Sir.
anybody your colleagues on the screen?
Yes, sir.
Please, can you identify?
Sir Kirti.
Okay, one is Kirti. Then ask the multiple people. Anyway, let me start with the Kirti. I think Dr. Shraddha. Please come on. Where is Dr. Kirti? I'm not getting her. He or she, I'm not sure. Yes, Abhiram, at least you can keep your video on. I think there should not be a problem. Whether Dr. Kirti is there? Abhiram, again you can help.
Sir, I think that she is having some technical problems.
Okay. Anyway, Abhiram, you can take it. Let you start it.
Sir.
That how you have interpreted this information regarding the weakness.
Sir, the patient is having a history for, sir, acute onset of weakness.
Right.
Mainly started in the lower limb, sir, then gradually progresses the upper limb by 3 days. Sir, initially the child was actually having weakness of the distal muscles. From the history, we can identify that the child mainly complains that he is having a complaint of his chappals or slippers are getting slipped off from the foot. That mainly denotes the weakness of distal muscles, sir. Then the difficulty in difficulty in standing up from squatting position mainly indicates the weakness of proximal muscles of lower limb, sir. Then we can identify this as a kind of an ascending paralysis.
Okay.
And later on, it moved on to upper limb, sir.
Why did you say it is the paralysis neurological cause? Cannot be anything else. Suppose I will say generalized weakness due to some other reason. Maybe the hypokalemia, I will say.
Sir.
Even periodic hyperkalemia can also present in this way.
Sir.
Right. Even any other reason for hypokalemia. Suppose in a case of chronic renal failure is going on, and now the patient has gone for the severe hypokalemia, that can also present in this way. So how will you differentiate or how will you justify your argument?
Sir, in case of periodic hypokalemic paralysis, the child will be having either any illnesses or any history of drug intake which leads to hypokalemia.
Okay.
Like there is no history of any loose stools, no history of any history related to any renal tubular acidosis, no history of any hyperthyroidism in this child, no history of any drugs which causes shift of potassium.
Dr. Abhiram, you must be knowing that these are the secondary causes for the hypokalemia. But periodic hypokalemia itself is a different entity.
Sir, primary causes is
there may be without any reason, and it develops periodically. Patient may go for recovery and then again develops. That of the story may be going on, right? But the point is, let me help you. Periodic hypokalemia, the weakness will be usually generalized, right? It will not be selectively lower limbs, then will progress to upper limbs, and then it becomes the generalized. We know that the hypokalemia itself is going to present as a whole, I will say, all the problems. So like that you can explain. Okay. Second thing I will say, as you said, this paralysis, lower limbs are involved, then the trunk, and then the upper limb. Okay. So what does it indicate? It's an acute onset, very rightly you said. Another thing what I want to convey to the students, that use the multiple adjectives. Here we can say it's an acute onset, right? It's an acute condition. Second thing, it is a progressive. Progress also you can see that within probably 24 or 48 hours, it has progressed. So how did it progress? It is a rapidly progressive. It's not slowly progressive. It's not the static. So we can say that this type of the weakness or the neurological condition started from the lower limbs, acute onset, It's a progressive, it is rapidly progressive, right? And that's the thing. Is it possible that it can be of, now, can you make the comment, it is of central origin or peripheral origin? Can you make any comment from this description? Even anybody?
Uh,
I hope this Dr. Ranjan, Dr. Twinkle, I'm not sure whether they are some faculties or students. Dr. Shraddha, please interact, come on, whatever comes to your mind. Okay, can you take Abhira?
Sir, mainly this is of sir. This is mainly due to the involvement of sir peripheral nerves, I think.
Why not central? I will say it is the central origin. How will you explain me?
Sir, from the history part, sir, mainly the progression of the disease, sir. This is very rapidly progressing and mainly started from the distal muscles, sir.
But you know,
That won't
suppose some part of the brain damage in such a way that first damage take place at the representation of the lower limbs. Then further progress of the disease in the brain, which involves even the trunk and lower limb. So the disease of the central system is spreading in this way. Even it can start in this fashion. May not be, I will say, so common. As I said, probably hardly it is seen in the practice, you are right. But what I mean to say, that distribution or the progress or the beginning may not be, I will say, sufficient point to explain. That means, are there any other arguments which differentiate the central origin and peripheral origin? Are you able to think? Yes, Dr. Aditi is seen. Aditi, I'm not sure whether, were you there? Have you listened to Aviram?
Yes, sir. Yes.
Okay, so can you differentiate the central origin and peripheral origin? What does this indicate in our case, and what are your explanations?
Sir, according to the history, it is likely a involvement of peripheral nervous system because there is no history of altered sensorium, no history of seizures. The arousability and awareness of the child seems to be normal.
Yeah. So, you know, usually the central origin, not only the motor deficit will be there. Along with the motor deficit, some other functions are going to be affected. And very rightly, Dr. Aditi saying, there may be even some altered sensorium, sometimes maybe the seizures, sometimes when the problem with the cognition or even the intellectual activity. No, we are expecting something. I think speech even, but here speech is involved, but in some other way. I'm coming to this point later on. So very absolutely right that it's a neurological condition. It's a lower motor neuron type of lesion. It is acute onset and it is progressive, ascending, progressive, rapidly progressive. At least this much we can understand from this complaint. Now let us go to the second complaint regarding the voice. Aditi, because you are there, you can take it. How you are interpreting the problem of the voice. I hope that you listened to Dr. Abhiram, that there was some change, nasal twang, even later on the nasal regurgitation, and with this one change in the voice. So if all the points you try to coin, what does it indicate?
Sir, the nasal twang, the nasal regurgitation, and the hoarseness of voice, it points towards a 9th and 10th cranial nerve involvement. Possibly there is bulbar dysfunction, sir. Bulbar
Right.
palsy.
Okay, so that's good thing. You know, again, that voice change and regurgitation certainly indicates this cranial nerve involvement. And second thing, even the same, if you go for the explanation for difficulty in swallowing, deglutition, again, this indicates that likely the involvement of cranial nerves and there are the 9, 10th, 11th. And you know that this involvement of the cranial nerves, even certainly you can make out that the bulbar involvement, right? So now we can understand that as a whole, if you want to interpret that this 10 years old girl has presented with acute illness, neurological condition, starting from the peripheral nervous system, it is acute or onset, it is progressive, rapidly progressive, and probably with the bulbar involvement. It was a very classical interpretation, you can make it. Even you can make the comment for likely pathology also, because we have somehow the good clarification. Anybody can make, I would say, try to understand that what are the other conditions which may present with this, not only one particular condition, multiple conditions can present. So make you some comment that which conditions can, suppose I will say 1.5 to 2 years old child has presented with not only the weakness, started with the nasal regurgitation, nasal twang, then this problem of regurgitation, and later on this, even I will say the weakness or lower motor neuron type of paralysis. Rather than starting with this ascending paralysis in a young baby, 2.5 to 3 years, it started with this nasal regurgitation, nasal twang, and even with this gradually progress to the peripheral, or I will say acute placid paralysis, with even the respiratory involvement, and occasionally we used to see even that such baby died. And if you go in the history, about 10 days, 2 weeks time back, child had some mild fever, even some difficulty in deglutition. Somehow child recovered from that, and after 2 to 3 weeks, this problem has developed. What is the likely cause? I have given so many, I will say, close to you.
Polio.
One more point I will say, classical I have said, not the polio. Polio will present, I will say, similar way to what you are describing.
Botulism.
It's a vaccine preventable. Dr. Monica has put on the, I will say, chat box as it is diphtheria. And post-diphtheria polyneuritis can present in this way. Very commonly, with this nasal regurgitation, nasal twang, change in the voice, later on develops this, I will say, paralysis, respiratory muscles involvement, and death. Fortunately, now with the good coverage, we don't come across these problems or complications, but we should keep in mind, botulism also, as somebody said, is right. Even some history of honey in very young baby may not be so common, but occasionally you may come across. So we'll have to keep in mind. Anyway, anything else? Somebody said polio. What will be the present? I think this generation is most lucky that you don't see the polio. But at least we should be aware of it, that how the poliomyelitis can present. Very close, I will say, differential diagnosis. Very close differential diagnosis of poliomyelitis. May not be in this time, but anybody can take it, please.
Polio,
So
there
there-
will be LMN paralysis.
Yes, I think Dr. Vadi Yashwant, which I am able to read, ready. Yes, please.
There
Very
will be
good.
fever. Fever will be preceding weakness, and there will be LMN paralysis.
Okay.
And these people also will get involved in dysphagia and nasal regurgitation.
May not be all the patients. That may go again with the bulbar, which may not
Bulbar
be all the
involvement.
patients of polio, but very classical presentation. Main differentiating point for, I will say, GBS and the polio. Poliomyelitis, usually it is with the fever. And usually GBS, during the development neurological presentation, fever is not there. That is very classical. Second, if you say, another thing here what Dr. Abhiram has described, it is very classical symmetrical. While in poliomyelitis, it is going to be patchy, asymmetrical. That is very characteristic. Let's suppose right upper limb is involved and something on the left lower limb, like that. And then maybe even the trunk involvement. It will not be the symmetrical. So asymmetrical. usually slowly progressive. Yes, even rapidly progressive polio also we have seen. And even so asymmetrical, patchy involvement with fever even and other manifestations, not vaccinated, maybe some triggering factor. That of the story we used to get very common with this poliomyelitis. But at this juncture, probably you may, but still you will have to keep in mind the differential diagnosis. We may be even due to the vaccine-associated problems. Maybe the web, or even maybe the circulating this virulent, I will say type strain of the poliovirus vaccine. So this is, again, we have to keep in mind in this era also. Anything else even presents with this type of the difficulty in deglutition and even this change in the voice? Actually, as a clinician, what I want to share with you, please keep every possibility in your mind. And therefore, what I want to share, as the patient starts to speak, mother start to speak, your thoughts should be in action. Think various reasons. You don't know that one particular reason. And if you are having this point in your mind, probably you'll be able to catch even the rare condition. I think somebody was telling myasthenia gravis, yes?
My estimate, there will be nasal speech and nasal regurgitation.
Okay, yes, but with that we have some other manifestations. But even the voice changes can also
there will be
same.
ptosis, diplopia.
Yeah, right. So ophthalmoplegia is very common in the myasthenia gravis. The first presentation, attention drawing complaint, or even I will say from distance you can see the ptosis and ophthalmoplegia. And just if you ask, in the morning person is better, but as probably with the activity, fatigability is there. So that of the story with the fatigability and precipitation of this type of the ophthalmoplegia, ptosis with the activity, very classical story. So I think, in the medicine, if you go for this type of the thoughts differentiation, that will provide lot many points. Now I think if you put all the points together, then the 10-year-old girl, duration of, I will say, less than 7 days, that means acute condition, no fever, that is very important point. On the contrary, Abhinam, you should mention over here that it is not with the fever. So many your thoughts will go down. And then you can say that this weakness.
Mentioned.
Okay, fine. Suppose weakness started from the lower limbs, progressively ascending, progressive, and even this involvement of this bulbar from these complications. Even here, why I'm coming to this point. As a clinician, our aim is not just to discuss our good performance in the exam. Ultimately, we want to practice it properly. But direct question to this, I will say, Dr. Yashwant Reddy. Suppose this patient, if you have suspected GBS clinically in the OPD, what is, I will say, your concern to this patient? What is your prediction? What is your worry? Dr. Yashwant Reddy, are you able to?
Reflexes will be absent.
Okay, that will be there. But I'm concerned with that some complication, problem. And why? That's very important point. As a clinician, always interpret it properly. Suppose if I am sitting in the OPD,
there will be,
and I will admit this patient, I will not just admit. I will call my colleague that please, I am sending this patient with this my suspicious. These are my problems and please take care. So what is your prediction? What is your concern?
Respiratory system gets involved.
Why? Because it can happen in any patient.
Weakness of diaphragm and intercostal muscles will get.
Rather than that, something else, which already we have discussed, we have pointed out. Bulbar involvement.
Bulbar weakness.
Bulbar involvement, I will say it's a
life-threatening.
Life-threatening. This baby can develop the problem at any time. And therefore, I will call my colleague that I am sending this patient, but immediately please take care and manage and be ready to face even any problem or complication. Second thing, even regarding prognosis also, I can predict. Reason is, it is a very fast progressive disease. very fast progress of the disease is also having not the good outcome. May not be in all the patients, but as a clinician, I will keep in mind. So actually what I want to share with you that just, I will say interpretation, considering diagnosis is not sufficient. But I will say in the first only 1 or 2 slides, we have discussed a lot, and I'm sure that now Dr. Biram, I think before that, you were any teacher, those who are present, you have any, please comment, you are always welcome. And please do it so that probably students will be benefited from all of us. Abhiram, you can go further with your history part. And again, we'll ask you to stop for the discussion.
So coming to the past history, there is no history of similar illness in the past. The patient had history of fever 1 month back, and after 3 to 4 days developed itchy fluid-filled skin lesions, which was first observed over the abdomen, then later spread to the upper and lower limbs. The child was taken to some local clinic and was diagnosed with chickenpox. No antiviral medications were taken. After 9 days, the child developed difficulty in breathing while playing, following which the patient was taken to UN Mehta Cardiology Hospital in Civil Hospital Campus, Ahmedabad, where a diagnosis of viral myocarditis complicated by dilated cardiomyopathy and moderate LV dysfunction was made. The patient was kept in airvo for 6 days and then discharged on tapering dose of steroids and antihypertensive medications. So these details I got from the discharge card of the patient, and the patient was discharged on tablet clonidine or carvedilol, then steroid prednisolone, enalapril, and aspirin.
That was just 10 days before this illness, right?
Sir.
Okay, okay.
Then coming to the family history, sir, there is no similar history of similar illness in the family. The child is second of birth order, born out of non-consanguineous marriage to a 32-year-old father and 30-year-old mother. Father is an auto rickshaw driver and mother is a home baker. Eldest daughter being 16 years old and youngest son being 8 years old. No history of any chronic illness in the family. Sir, according to modified Kupusamy scale, the family belongs to lower middle class, socio-economic class. So coming to the birth history, the patient delivered in a government hospital, Daga. It was a full-time operative mode of delivery. Delivered a male child of 3.5 kg of birth weight and the Brady carried soon after birth. There is no history of any NICU admissions. According to the mother, breastfeeding initiated within 4 hours of delivery and the child was exclusively breastfed till 6 months of age. Said the immunization history, all the vaccines were taken according to national immunization schedule at appropriate age, and the last vaccine taken being DPT booster 2 at 5 years of age. Then dietary history, according to the pre-illness 24-hour recall method, I came to the conclusion that there is a calorie deficit of 430 kilocalories per day and a protein deficit of 10 grams per day. So in developmental history, for this 10-year-old child, it was up to age. The child is now studying in 5th standard and average in scholastic performance, and he helped his mother in household activities during the pre-illness period.
Okay, can you stop sharing for a while? For
yes.
History part is over. I think something interesting history he has derived. Anybody else have the comment? I think first the student should make the comment. Yes, anybody? What he provided the further information. He said that no history of similar illness in the past. Anybody has the comment on this information? Later on, related to the chickenpox, we can come forward. Let us first, I will say, take the chickenpox. Very, very classically, he described, convincing probably, and naturally she was not vaccinated because followed the national immunization program, and we know national program does not include the varicella vaccine. And she developed probably convincing varicella as a probably complication, even the myocarditis and cardiomyopathy. Very appropriately described the course of the illness in the cardiology unit institution. And now after 10 days or so, this problem. So how you have some link, or both the illnesses are different, what will be your comment? Yes, anybody?
Viral pathology.
Dr. Yashwant, ready? What is your
Viral
comment?
viral pathology, it is prolonging the disease.
Dr. Reddy, my question is very clear, and I even the many times convey to the student that question is precise, answer should be so precise. Whether the chickenpox and this neurological problem, whether both the illnesses are different, or you are having the link with these two. And suppose link, then what is the link? Yes, Dr. Ashwin, what is your comment? What is your thought? How you are looking at these problems? Different or having some link between these two?
Sir, in the post-varicella phase, the child may be having vasculitis, and varicella itself can directly cause neuropathy, and the vasculitis that happens in the post-varicella infection phase that can cause neuropathy.
Okay.
There is one differential, sir, that I can put forward.
Right. Anything else? How you are explaining the vasculitis causes peripheral neuropathy? Dr. Abhiram, what is your thought? What is your idea?
Sir, the microvessels that supplies the nerves, if that gets affected by vasculitis.
Your logic is good, but I think commonly it does not happen so. On the contrary, please remember, suppose post-chickenpox vasculitis, neurological complication, how the patient presents. That you should know. Suppose early chickenpox, and it's a post-chickenpox vasculitis, and patient has presented to you with a neurological complication. How they present?
Sir, the pain is more of a neuritic type.
Common presentation, please. Always don't try to guess, but I hope that if you have read or if you are aware, if you have seen the patient, probably will never forget it.
Ataxia.
Yes, Dr. Ashwant?
Ataxia.
One is the yes, post-varicella cerebralitis, and therefore presentation of ataxia and other thing. That is one problem or complication. It is, I would say, cerebralitis. It is again inflammation. But here Abhiram says vasculitis, and vasculitis is also known, and known even to present as a neurological complication. Please remember that presence as a stroke. Post-chickenpox vasculitis presents as a stroke. I will say chickenpox, or I will say with the chickenpox cerebralitis, that is the inflammation, and then may present with the ataxia. Even varicella can cause encephalitis, which is common particularly in the older children, adolescents, those who are not vaccinated. And therefore, older children, adolescents, varicella is dangerous. More problems, more complications. We are afraid of it. And of course, even if you check it, even chickenpox, post-chickenpox, peripheral nervous system complication, even the GBS, yes, it is known, it can cause it. So the best way to explain post-chickenpox here, unfortunately, chickenpox, these problems or complications, carditis and neurological, known. Unfortunately, this child developed both the problems, which already you say in the form of the myocarditis and cardiomyopathy and related problems. So that is number one. Can you say what other viral infections are known to cause this GBS? Anybody? Other virals even. You should know, sometimes even you may get the history in some other patient. Anybody? Yes, Dr. Monica, influenza, very good. Rather than influenza, then common. Influenza vaccine causes. Yes, Dr. Pranshul, enterovirus. Enterovirus usually causes the polio-like manifestations. But for the GBS,
CMV.
CMV, entero, even the EBV, infectious mononucleosis, these viruses are known to cause even this type of the problem. Which vaccines can cause this GBS? He said some vaccines are having the link with this.
Sir, influenza vaccine.
Influenza.
Influenza vaccine, yes, very good. Any other vaccine?
Sir, yellow fever, sir.
Yellow fever, I am not sure. Because if I am not sure, I
Rabies.
should not answer.
Rabies
Okay.
and polio.
Rabies, rabies will cause the rabies itself. It will not cause the GBS. But particularly two vaccines,
The COVID vaccine.
hepatitis B vaccine and even the influenza vaccine. They are known having the association with this, even the GBS. Even rabies can, rabies particularly, rather than we'll call the GBS, rabies causes the lower motor neuron type of paralysis. That's a different story. Anyway, so I
Sir,
think the...
Sir, can I speak?
Yes, sir, Sandeep, everybody is, please.
Yes, sir. If rabies vaccine having transverse myelitis, sir?
Rabies, rabies vaccine can cause, not the, I will say, modern vaccines. What we used to, I will say, give in the past, equine variety. That was known to cause even this post vaccination polyneuritis and even the encephalitis, and sometimes even the death.
Because
So-
of I have seen one patient from my area to I am admitted, and then after patient is going to a respiratory arrest after when sending the Ahmedabad, sir.
It is known. Many times on the contrary, now this modern, I will say, safe vaccines are available. So these vaccines are not responsible, fortunately, to these complications. But equine, I will say, preparation, which we are using in the past over the abdomen, very classically, these vaccines were, on the contrary, retrospectively, many times we felt that probably rabies might have not developed, but the rabies vaccine created this complication. So I think all these problems, we should be aware of it. What other history you will ask, suppose if you are thinking for this type of the problem of GBS, what very specific another history? Dr. Pranshu Chaudhary is putting on the, I will say, chat box. Let me ask. Dr. Pranshu, is there any other history important? In the past, I will say 10 days, 2 weeks back, and then the manifestation of GBS. Anybody? Abhiram, you can.
Sir, we can ask about diarrhea, history
Very
of
good.
diarrhea, loose stools.
Very good.
In the
Yes,
patient,
Dr.
sir.
Kirti. Anything else? That is one. That is GI symptoms. Commonly, what type of diarrhea? Usually the dysentery.
Yes.
Which particular organism you are suspecting for this reason?
The Campylobacter.
Sir, Campylobacter.
Very good. So Campylobacter. Similarly, any other respiratory?
The Mycoplasma.
Asthma.
Yes, very good. Very good. And recently, some of the centers have noted more incidence of the GBS following Mycoplasma. Even they have documented. Some of our, I will say, neurologist friends, like Dr. Rajesh Sudhani and others even, they have noted that some incidence of GBS is reported more in the recent time. And there were some of the centers noted even the outbreak of the Mycoplasma, and that I will say Pune people probably reported even this situation. So Mycoplasma is known. GI symptoms, we can cause it. So always this type of history we should include in the, I will say, our description, so that does it, I will say, in any way contributing to this problem or not, we can describe. Another thing he has mentioned, no history of similar illness in the past. So Dr. Kirti, my question to you, suppose if you are thinking for the GBS is known to develop recurrently. Suppose already treated, recovered, and again, can it develop? Anybody? Or Dr. Kirti, Abhiram, Dr. Yashwant,
Sir,
because now I'm able to identify some of the students. Yes, Dr. Kirti.
Yes, sir, GBS can have
Sorry, there is some problem of a network issue. Not your voice is clear. Yes, Abhiram,
Sir,
you had some
sir, actually-
comment.
Sir, it is mainly I asked that question mainly to rule out the recurrence of GBS. There is an entity called recurrent GBS. And sir, in case of familial periodic paralysis, there will be a history of recurrent paralysis.
Right. Even 2 points. Very absolutely he is right, Abhiram, that even the recurrence of these are the problem rather than GBS, you may think for periodic paralysis. Right. But even occasionally it has been reported in the literature, the recurrence of the GBS, not so common in the practice, but yes, it has been reported in literature. So we should be aware of it. You know, examiner does not want the exact your case. He wants to assess that how much you know the subject. Now, Abhinam, I will say small summary from you. And you know, summary is not the repetition of the same thing which already we have discussed. Summary in the short regarding indicating your hypothesis. And here keep in mind, what is the site of lesion in neurology, what is the likely pathology and possible etiology. Like that, you should make the comment. Anybody, I think before Abhiram, let me ask Dr. Kirti, Yashwant, those who have not probably seen the patient. Anybody? Can you make this small summary? You know, this is now very common in the exam. That from the history, make the small summary. Anybody, please make the attempt. If you, I will say, do multiple times, then certainly you will be able to do in a better way. So you should always try. And I wish that students should do voluntarily. Dr. Rashmika, would you like to make the attempt to put the summary? Another thing which I want to sensitize the student, that please don't shy away from speaking or making the comments or the questions. On the contrary, very freely we should do it. May be wrong, may not be even good, up to the mark or performance, but that's the way that how all of us can learn. Anyway, Dr. Abhiram, can you make it?
Sir,
short summary.
10-year-old male child presented with acute onset of ascending type of paralysis with associated symptoms suggestive of bulbar palsy.
Very good.
With sir nutritional status of sir probably severe undernutrition be
okay,
because there is a significant calorie deficit and protein deficit in the
right. Your focus should be on the problem. Your focus, you know, in the summary, that means what points you have derived and how you are utilizing in making the decision. Try to develop that skill. You know how simply we can make it. I will say short summary over here. Sir, here 10 years old female has presented with acute illness. Acute illness indicates the problem with the acute flaccid paralysis, because now you can make the comment. And that is acute on onset, ascending variety, rapidly progressive. Now even it has involved the bulbar also, particularly with the involvement of voice, change in the voice, and even difficulty in deglutition. Having this going in the details of the history, I came to know that she had the chickenpox about 2 weeks back. From the history, it becomes very classical chickenpox. Following that, she had the myocarditis, very bad episode, required the hospitalization of the cardiac unit, treated for the myocarditis and with some drugs. Now, having this, I will say, neurological presentation with a peripheral nerve complication, I presume that again probably it is the Guillain-Barré syndrome-like manifestation following the chickenpox. You can make the comment in this way. The rest of the points I tried to go in the details, but not supporting of any GI symptoms or respiratory symptoms or any specific vaccination or any past history or family history are not contributing. So that, you know, everything becomes very clear. So that's the thing, that how we can make the short summary. But I will appreciate that Abhiram has made the really very good presentation in the history part. Very appropriately has included the points put it very appropriately, even describe with more clarity. And I'm sure that this of the presentation is going to be quite useful. Abhiram, now we can start with your, I will say, examination. Before that, I can see some of the teachers on the screen. So I request them that please, if you have any point, comments, please contribute. Particularly, I know Dr. Anand has just probably joined, but he's one of the, I will say, best teachers who can even contribute, explain, and particularly neurology is of his interest. Anyway, I think as he gets more information, he will do. So Abhiram, now you can go for the examination because I am looking at the time also.
So coming to general examination, I have obtained the consent for examination from the mother and I examined the child in supine, side lateral and supported sitting position in good light exposure. So from head to toe examination, the child was well built and moderately nourished, and the skull size and shape were normal, and hair short and dense. Eyes, some pallor present and hypochromic iris were present. Ears and nose were normal, and oral cavity, observed dental caries were present. Then skin over the trunk and limb shows ulcerations over healed lesions of varicella infection. So neck was normal. The size and shape of chest and abdomen were normal. Umbilicus was normal. Extant genitalia normal in size and circumcised foreskin. Bilateral testis purple in the scrotum. Sir, upper limbs kept in neutral position. Decreased muscle mass observed. Lower limbs both are kept in extended position with everted foot. Sir, spine examination. There were no kyphoscoliosis, no surgical scars, no injection marks, no tenderness, and no nodularities over the spine. Sir, there is no icterus, cyanosis, lymphadenopathy, and pedal observed. Sir, coming to anthropometry, it come to the conclusion that the BMI was 13. Then head circumference of 53 centimeter. Then it comes to the vitals. Temperature was 98 °F on right axilla, measured by digital thermometer. Periphery is warm on touch. Pulse was 88 per minute, well palpable. Regular rhythm, normal volume and character, no radiofemoral delay. Respiratory rate was 19 per minute, abdominothoracic, and normal pattern of respiration. Blood pressure was 147 over 96 millimeters of mercury, measured on left upper arm in lying position. And this comes more than 95th centile for the age. So coming to the examination
anyway,
of the central
level. Can you stop sharing for a while before you go for the CNS? Probably
Yes,
we may forget your findings on general examination. Any comment from general examination, any student? Or if you want more information, suppose he has not included. Anybody? Dr. Yashwant? Dr. Kirti? Anybody? Yes, Dr. Yashwant?
Facial weakness.
What you want? Facial weakness? Whether he has forgotten? Or...
Nasal speech.
Okay. Very
and
good.
Whether the limbs were hypotonic or...
Right. I think that he might have included the CNS. But from facial weakness, what you want?
Seventh now involvement.
Okay. So you want the clarification whether seventh is involved or not. Probably he has not described. So presume that it is not there, and more probably he will include in CNS. But anything from this, what he had mentioned. I think number one, let me tell before I forget to all the students and Dr. Abhiram, general examination findings should be in chronology, some sequence. You started, then these genitals, then the upper limbs, and then no icterus. I think that sequence is not maintained. As if we are examining the patient from head, then the eyes, then throat, then it is neck, upper limbs. Like that, I will say sequence should come. And then naturally the genitals. So probably always try to maintain the sequence. That is very important. Second, make the comment in such patients regarding the position. Suppose in this type of the power grade 0 or 1 even, very classical position of the patient may be there in the supine position. If really it is very specific attention drawing, that you should mention. Very rightly you I will say commented on nutrition and general build-up of the patient. That's right. Now, any comment on these vitals? Anybody? Dr. Kirti, are you there? I think Dr. Twinkle, I hope that she's a student. Dr. Prachi. Dr. Prachi, any your comment on these vitals? Yes, Dr. Kirti, any comment on the vitals? Okay. Somebody is putting in the chat box, but I think better to.
Sir, the BP, the blood pressure is slightly on the higher side, sir.
What is the, even he has mentioned the percentile. What is the percentile, Abhiram?
Sir, sir, it looks like more than 95th centile.
I think he has mentioned. Abhiram, can you make the point clear?
Yes, sir. It was more than 95th centile for the age.
Okay, then Kirti, how will you interpret it? It's a
Sir,
hypertension.
it seems that there were signs of autonomic instability, sir.
No, I will say the point. It first make the point clear that yes, it is the hypertension.
Yes, sir.
Right. And then you should look for your other points. Suppose you are suspecting autonomous nervous system disturbances. What other thing you will check? I think very important pulse. That may be the tachycardia. Somehow it is not there. Very important point, I will say respiratory system examination, particularly respiration rate.
Yes.
Not only the rate, you should look for that is the movement of this, even the chest or thorax. What is the movement of the diaphragm? Better to, I will say, mention over here. And for that, I will say respiratory muscle weakness. What test you will do, Dr. Kirti?
Single breath count test. Single breath count test.
Yashwant, what is the single breath count? Can you describe it? You know, people, I will say this is very important, even in the practice also. In the such patients you are monitoring, then daily in the round, you should check it. That will give the idea whether the child is developing this respiratory muscle weakness or not. So Yashwant, can you describe the single breath count?
Yes. Sir, we ask the patient to take a deep breath and ask him to count 1, 2, 3, 4 and then normal speaking. Then
loud speaking.
Loud speak.
Yeah.
Then until he takes the next breath, we count the count, how much it goes.
Yeah. What is normal and what is cutoff?
Sir, normal will be more than 25.
What
What
is the good one? What is the good one? That means normal person, healthy and hearty, even very young person like you.
Sir, it is around 30, sir.
50, even Kirti.
Okay, sir.
So please remember, most of the people will be able to do around 40, 50. So very rightly, Yashwant described, ask the person to take first deep inspiration and they count loudly 1, 2, 3, 4 like that. Not 1, 2, 3, 4. Like loudly. And see that till the next he take the breath up to what he is able to count. Most of the normal healthy people will be able to do 40, 50. But what is the cutoff to say that it is a respiratory muscle weakness?
15.
15. So that's very important. So remember 15 and 50 so that you will not forget it. That normal usually around 50, less than 15 or 15, it indicates respiratory. And single breath count is a very good, I will say, bedside test to assess the function, particularly when the vital capacity of the lungs, and that is the functioning of the respiratory muscles. So that you can do. See even the movement of the diaphragm. Suppose if there is an involvement of the respiratory muscles, there may be some paradoxical movement, even there is suppose paralysis of diaphragm even. So all these points should be checked. Coming back to even the autonomous, Dr. Kirti, what will be the other manifestations? May not be all in one patient, but if you are knowing, you will check it. One is always check for the tachycardia or any, just I would say rhythm, hypertension, anything else?
The tachycardia or bradycardia.
Okay. Anything else still?
Sir,
Excessive sweat.
increased sweating, sir.
Excessive sweating.
Sweating.
So sweating is there, tachycardia is there, hypertension is there. I think these are the signs of autonomous nervous system. Now, Kirti, direct question to you. Suppose if it indicates an autonomous nervous system involvement, does it make any difference in your prediction, in your understanding? You know, ultimately, as a clinician, we are not just here to see the sign. How you take it, how you interpret it, that is very important. Anybody? Abhiram, any idea? Suppose some patient is excessive sweating, tachycardia, hypertension, and already you are suspecting that yes, it's a case of GBS. Then how will you take it?
Sir, this denotes a rapid progression of the disease.
Very rapid, rather than rapid progression, you know, it indicates.
Life
I will say it's a bad predictor for the outcome. It's not good predictor. So with the autonomous nervous system, I'm expecting more problems and complications. And probably outcome compared to others may not be that favorable. May not be always life-threatening, but yes, presence of autonomous nervous system disturbances is not the good sign. At least that much you can take it. So what was my idea? That you should look for the things which you are expecting, check it, any presence or absence. That will give you some idea regarding the severity, progress, and even the further management. And even you can speak a word of caution in the prognosis to the parents. So that's the thing that how you will take it, right? So I think now we can go for, because I'm looking at the time also. I think before that, please wait for a minute. Yes, Abhiram. Any other teacher, any comment? I know that so many teachers are there and they must have some ideas. Okay, then Abhiram, you can take it further. CNS examination.
Sir, coming to the examination of central nervous system. Sir, examination of higher mental functions, the patient was conscious and oriented, and higher mental functions were normal except for speech. The patient was having flaccid kind of dysarthria with impaired production of bilabial sounds such as ma, pa, and ba. Sir, examination of motor system. First, posture. The posture was supine with a partially flexed upper limbs and extendedly rotated lower limbs. Muscular volume is markedly equally reduced bilaterally. Then muscle girth of corresponding points were bilaterally equal. Gait, the child was unable to walk. Then coming to the muscle tone. Sir, there will be reduction in the tone of muscles on both sides, both on upper limbs and lower limbs. Sir, as compared to upper limb, I have observed a marked reduction in tone mainly on the lower limbs. And the tone of neck muscles and muscles of trunk were observed to be normal. Then coming to the muscle power, and sir, according to the MRC grading, the power of shoulder flexors, shoulder extensor, and shoulder abductors, adductors, shoulder internal rotators, and external rotators found to be having a power of grade 3 on both sides. Then sir, elbow muscles, elbow flexors, extensors. Then sir, wrist flexors and wrist extensors were having a grade of 3 on both sides. Then coming to the distal muscles of upper limb, both adductors and abductors of the finger were having a power of only 2, sir. Then coming to the power of lower limb muscles, all the muscles of hip, including fluxes, extensors, adductors, abductors, internal and external rotators, were having 0 grade of power, sir. Then the muscles of knee, both extensors and flexors, were having 0 grade on both sides. And sir, ankle, dorsiflexors and plantar flexors were also having a grade of 0. Then sir, coming to the neck flexors and extensors, sir, the power was actually adequate. There is wrong in mentioning here. Then power of respiratory muscles, I have assessed the power of diaphragm. There is no paradoxical breathing observed, and I have assessed the single breath count. The breath count was 32 per single breath. Then no signs of usage of any accessory muscles of respiration. Sir, coming to the superficial reflexes, corneal and conjunctival reflexes absent on both sides. Gag reflex absent on both sides. Plantar reflex absent on both sides. Then the superficial abdominal reflexes were also absent on both sides. So coming to the deep tendon reflexes, all the deep tendon reflexes were observed to be having a grade of 0 on both sides. This denotes areflexia. Sir, coming to the test for coordination or cerebellar function, gait, yeah, I couldn't assess the gait because the child was unable to walk. Sir, there is no observed titubation, nystagmus, scant speech, or intentional tremors. Sir, the coordination tests carried out in the upper limb, mainly the finger to nose test and finger to finger test, were found to be normal, and there is no dysdiadocognitia present. So, the below mentioned tests for coordination in lower limbs were unable to perform because the power obtained in lower limbs were less than grade 3. Hence, heel to knee test and tandem walking was unable to perform. So, coming to the examination of sensory system, first coming to the peripheral sensations, fine touch, through touch, pain and temperature, joint position and proprioception, pressure sensation, vibrations, and found to be normal in all the dermatomes. So cortical sensations, mainly the tactile localization, 2-point discrimination, stereognosis, and graphesthesia were found to be normal. So coming to the cranial nerve examination, there were no abnormalities in cranial nerves 1, 2, 3, 4, 5, 6, 8, 11, and 12. But in facial nerve examination, sir, there is bilateral symmetrical weakness in both in muscles of face. No prominent nasolabial folds on both sides. Patient is unable to close eyes completely, blow out his cheeks, or clench his teeth. But Bell's phenomenon was present. No prominent forehead wrinkling observed on both sides. There is absent corneal and conjunctival reflex. Taste sensation or anterior two-thirds of the tongue was found to be normal. And lacrimation and salivation were also found to be normal. So coming to the examination, glossopharyngeal and vagal nerve, uvula was midline in position. Diminished palatal arch movements were observed. So gag reflex on both sides were absent. Nasal tongue of voice was present. Sir, coming to the signs of meningeal irritation, there is no neck stiffness and there is no identified Kernig or Brzezinski sign. Coming to the examination of other systems, sir, CVS examination, S1, S2 were normal. No murmurs observed. Respiratory system, bilateral chest rise equal, no paradoxical breathing, bilateral air entry equal, vesicular breath sets observed on all auscultation areas, no added sounds observed. Per abdomen examination, abdomen was soft, non-distended, non-tender, bladder not palpable. Sir, coming to the provisional diagnosis, there is ascending type of acute flaccid paralysis with bulbar palsy and bilateral element type of facial nerve palsy, probably Guillain-Barré syndrome with dysautonomia with a Hughes disability grade 4 with associated varicella gangrenosum and severe undernutrition.
Okay. Can you stop sharing, I think, before you go for the investigations? Yeah. Any other student, any question for your colleague, Dr. Abhiram? Always, I think you should have a lot of questions for your colleague. So there will be the good competition in learning. Kirti, I hope that both of you are from the same batch. Dr. Kirti? Or you are from different institutions? Sorry, your voice is not reaching. Abhiram?
Yes, sir.
Both of you are from the same institution or different?
Sir, we are from the same college and she's my colleague, sir.
Yeah, so I think there should be a good competition. So Kirti should say that this, whatever your findings are there, I don't agree. Kirti, I think that should be the good comment. We were really, I will say, interacting with that spirit. Okay, later on you can say, oh, you can consider, but immediate reaction should be like that. Kirti, do you agree with him? Absolutely. Or you have some points to say or some questions for him? Yashwant? Anybody else? Dr. Twinkle, Shraddha, I hope that they are silent, but they should make the comment. Kirti, then directly I have the question for you. Can you, yeah. Can you make the comment regarding his chronology of CNS examination? Whether do you agree? So what you have to present, you will do in the same fashion or you will do in some other way. Any comment? I know Dr. Anand has discussed, Dr. Anand Keshwan, he's from Thrissur. He's a very good teacher. He always says that the examination should be in chronology, particularly the CNS, the way which you are describing. So, Abhiram, that is very important. CNS, how? First, higher functions, then the cranial nerves. You have taken the cranial nerves, I will say, at the end. So, always first higher functions, then cranial nerves, then go the motor system. Motor system 5 point. Motor system 5 point in the form of the muscle tone, muscle power, nutrition, coordination, involuntary movements. Then you shall go for sensory, that is cortical, and
cerebellar
then
functions.
peripheral. Then go for, I will say, signs of Menge irritation, cerebellar signs, extracellular signs, if any. Then you can go for gait, skull, spine. Always at least the chronology should be there so that you will not miss, and that will give some idea also that what type of problem it is. Anatomically, which part of the nervous system is affected, in what way is affected, what is likely pathology, because you know all the thoughts can be derived from your findings, and that probably creates some good picture regarding the disease process. So that's the thing, that number one, it should be chronology. Now, anybody will, another thing what he said, that the speech is affected in the higher function. In what way the speech is affected over here? Anybody can make the comment? Anybody? You know, speech can be affected in a different fashion. One is due to the central problem. That may be the motor or sensory, what we say Broca's areas and other areas. So another thing that is regarding central problem. There may be the problem with the phonation, and that will basically affected with the vocal cords due to the various reasons. Maybe the recurrent laryngeal nerve, due to this even this bulbar involvement, different reasons. Maybe some mass even pressing over that. Simple viral infection can make the hoarseness. Hypothyroidism can make the hoarseness due to vocal cord thickening. So reasons are different, but that will be the vocal cord problem. Further, even there may be the problem with the articulation. Nasal twang, what you said, is the problem of articulation. Or even there may be some functional problem, stammering. It's a functional problem, nothing to do. So always try to define that speech is supposed affected in what way. Where is the site of problem? I think here it is not the central problem. Already we clarified. The speech is affected due to this bulbar problem, due to the vocal cord involvement, due to this very specific cranial nerve involvement. So it makes difference. And that will give the, as I was discussing, it will give some idea that which part of the CNS is affected. Anyway, similarly, you said one neck tone is normal and power grade 0.
Sir, actually, that was a mistake, sir.
Yeah, okay.
Yeah.
So no problem, no problem. But what I mean to say, don't contradict your own finding. In exam also, after findings, confirm and put on the paper that what you are, and every time findings may not be clear. Suppose some ambiguity, even you can keep this. If you are not able to explain even, you can say that this finding is there. Suppose plantar is extensor. Not, I will say, explainable as per your discussion. But don't modify, don't manipulate the finding. That is another thing I will say from exam point of view I'm talking, because it creates a problem. You may not be able to explain. Okay, keep it open. Somebody else will explain. Or sometimes it may not be explainable. That may turn out to be later on that why the plantar was extensor. Immediate, there may not be the manifestation of upper motor other findings. So that's the thing that how you should do it. Now this, any person, that what will be the summary of the positive findings of CNS? In our case, we know, because that will give some picture that what part of the CNS is affected, what is the likely pathology, that will give the idea. So who will put this summary of the findings, CNS findings, already has described in details. Who will do? Please, one person. Yes, Yashwant Reddy, can you try? Yashwant? Can you, I hope that you are able to recollect his findings. Can you put, I will say, in a positive findings only. And then from the positive finding, try to think that which part of the, in the CNS always what we do, I will say in any system, but try to define the anatomy. That where is the lesion? Second thing, try to think that what is the pathology. And then even you can put the various possibilities of etiology. I will say that type of thought process is always going to be impressive. Anyone will give you the good idea for further workup and investigations. So, Dr. Yashwant, please do it.
Anji, Acho.
Yes?
Good evening, doctor. You cannot actually work out medical check at hospital, you know.
Yashwant, would you like to do it?
The one in higher function.
Don't hesitate. Whatever you are able to recollect, even put it, I will help you.
Sir, in higher functions, there is flaccid dysarthria.
Wait, right.
Dr. Alok, can you mute yourself, please? Please. Dr. Alok Bandari. Sir, can you mute yourself? Yes, Yashwant? Already we discussed that is the involvement due to the cranial nerves. It is not due to the motor aphasia or not due to any sensory involvement, right?
No.
So in one line you can answer that the higher functions are normal.
127 centimeters.
Right. Then cranial nerves?
Seventh nerve is involved.
Okay. How will you able to interpret the bilateral seventh nerve? Dr. Alok Bandari, sir, can you mute yourself, please? Dr. Alok Bandari, please mute yourself. Yashwant, how will you able to interpret the bilateral seventh of palsy?
Bilateral nasolabial folds.
Okay.
And unable to close eyes completely.
Is it lower motor type or upper motor neuron type? Facial palsy is upper motor type or lower motor neuron type? What is your interpretation?
For this patient.
Yeah, naturally, for this patient I'm talking. Abhiram, what is your interpretation?
Sir, the palsy was of element type because there is absence of forehead wrinklings. And sir, the Bell's phenomenon was present, sir, bilaterally.
Okay.
That won't be there in human type of facial palsy.
Okay. So lower motor body, the site of lesion, facial
Sir,
nerve.
sir, from the sir, in this case, probably proximal to the origin of chorda tympani, sir.
Okay.
Because the sensation over the anterior two-thirds of the tongue were preserved.
Okay. That means not at least
Sir,
the
sorry, sir, distal to the chorda tympani.
So then not at least at the exit from the stylomastoid foramen. Am I
Yes,
right?
sir.
Before
Yes, sir.
that. Before that. Okay. So any other cranial nerve? Seventh nerve is involved. Yashwant, any other cranial nerve? Speech is affected.
Speech affected.
Even this nasal twang is there. Even he said gag reflex is absent. So all these findings, what they indicate?
Glossopharyngeal nerve.
Okay. So 9th and 10th even.
9th and 10th.
Yeah, 9th and 10th, 7th, 9th, 10th now, you can say. Any other cranial nerve is involved, Dr. Abhiram?
Sir, mainly sir, 7th,
Hmm.
7th and 7th, 9th and 10th were involved, sir, in this
Okay.
case.
So these are the cranial. First, that's why I'm telling you the exam also. Determine your mind that what are your findings. So cranial nerves point of view, okay. Yashwant, motor system point of view. Motor system. What is your interpretation? Make, I will say, one line. Early hypotonia, power grade 0 or some 1, 2, 3, areflexia. So it is very classical, you can say lower motor neuron type of lesion. Right? Sensory, almost he has said normal. Signs of major irritation absent. Cerebellum signs are not there. Right, gait and other things he could not examine. Bladder not palpable is very important. That means bladder involvement is not there in this patient. Now, if you put all the points together and there is other systems are normal. So how will you interpret it? Dr. Kirti, can you say now the interpretation of CNS findings? CNS finding, I will say shortly, suppose if you have to present the positive finding, you can say that the higher functions near normal, 7th, 9th and 10th cranial nerves are involved, generalized hypotonia, power is affected differently, but certainly affected less than 3 or around 3, areflexia, and other systems are normal. So it becomes a very classical picture of acute flaccid paralysis. Try to, I will say, make in this with even the bulbar involvement. Because these 3 cranial nerves are involved. Always, I think that is the point that how you should make even in the exam. It becomes a very impressive. Okay, you may not be able to make the diagnosis in every patient, but you can convince your examiners your findings. Even suppose somebody is asking, you can demonstrate. Suppose if you can demonstrate, it is accordingly, I will say your interpretation, it becomes impressive in the exam. So these type of the exercises should be done multiple times so that you can develop the confidence. And other systems are normal. So now, what are the possibilities? Because already we described that 10 years old female has presented acutely with this acute flaccid paralysis. Now you can make the bold statement, and it is in the form of the acute, it is ascending, it is progressive, rapidly progressive, with involvement of bulbar and even the disturbances of autonervous system involvement, particularly due from the hypertension, you can say. Now, having this, what will be our possibilities? Let me start to Yashwant, then Kirti, and last Abhiram. And even other students, if you are, I will say, putting their diagnosis, they are most welcome. Yashwant, what is your interpretation? How will you put the differential diagnosis?
First one will be GBS, sir.
Okay. How? You will have to explain. I will
One,
say, suppose in some other way, I will say it is the poliomyelitis, because I have seen lot many patients when I was young junior person. That's why I will say it is the poliomyelitis. Now you convince me why not polio and why GBS.
So GBS, there will be paralysis will be starts from hours to 10 days, but polio there will be 24 to 48 hours.
Okay.
And cranial nerve involvement 7, 9, 10 involving GBS.
Is it not possible in polio? I have seen the polio due to the bulbar involvement.
In polio, only when bulbar involvement is present.
But here also, that's why I say it is bulbar involvement. So it is polio. You know, this is the thing that how you explain the exam.
Sir, in polio.
Abhiram will have to wait because you must have come with the preparation. Let me ask to Kirti. Kirti, I think you can use your mic properly. You are not audible properly. There's some problem of your voice.
Of fever, sir, which is not been seen in this patient.
Okay, very good point. Agree. Further. Further. At least I will give some of the ideas. In any condition.
Asymmetrical paralysis will be seen in polio.
Okay, that is good. Good argument. Agreed. Anything else? Very good point. Anything else? I think Dr. Vagasia is trying to come forward and again he makes it up. Kirti, I think I can make your video on so that I can understand, I can know the students.
As this patient is having a raised blood pressure, blood pressure seen in GBS, autonomic signs.
Dr. Yashwant, we used to see the hypertension in polio also, for your kind information. So I think you should have some bold, convincing point to the examiner that don't think the polio. Why? You know, number one, always any disease try to think with some epidemic or current status of the disease. You can say that in current status of the polio control, possible polio, but I will keep it at the bottom. Not at the first, I will say possibility. You can make the very bold statement. And I'm sure that examiner will accept it. When the Kirti last polio case was reported in India?
Sir, in 2011, I guess, sir.
Yeah.
In
What
was January.
What was the date? What was the date?
Sir, January 13th.
Yeah, because I remember it was on previous day of Makar Sankranti. 13th January 2011. Since 15 years at least, there is no wild polio. And that is become my strong argument. That's why I will, if at all it is, I will keep at the bottom. Of course, even vaccine-associated polio will have to keep in mind. But that I will keep at the again bottom, not as the first possibility. That you can make it. Second, what is the age of the patient? 10 years. 10 years is not the common age for the poliomyelitis. Poliomyelitis develops at the young age. We used to see the patients at the very young age. GBS has older children. The difference is there. Second, the epidemic, and third, how the disease started. You know, it is ascending, progressive, symmetrical. It is said that for the GBS, dogmatically to say there should be 3 points. Number one, fever should not be there. Presence of fever does not favor me. Then something else, even polio or something else. And here fever is not there. When the neurological manifestation starts, and suppose fever is there in GBS, Pakka GBS, then probably progress is something else. So that's a strong point that this is a very classical story, the way in which the disease should present. Absence of fever, acutely, starting from periphery, ascending, symmetrical. That is very classical story. Second, hypotonic areflexia is another point to say this. Third point, I think that you can do later on, that it remains static for a few weeks and then starts to recover. Or even some problem or complication. That is a very classical story of GBS. And therefore you can say that it is convincing to me GBS. Of course, other possibilities we'll have to keep in mind that you can say even the vaccine-associated paralytic polio in any form. You can say even in the form of even the botulism, somebody was talking, periodic paralysis, this may be the first episode. Following chickenpox, yes, that's why you can keep in mind even the GBS. But any other condition which presents active settle, if I give the one scenario, please all the students attentively listen to me. Similarly, 10 years old girl or boy, absolutely fine, previous evening, went to sleep from the farmer family. And next day morning, mother found having some problem, vomiting or something, one or two, and again, suddenly mother found her not able to walk. And very suddenly even respiratory involvement and even CNS involvement.
Sir, OP poisoning.
Snake bite.
Very good. Who spoke the snake bite? Please
Yes, sir.
identify yourself.
Sir Ritesh.
Yeah. Why I'm telling you that this is very classical story of the snake bite, and keep in mind, some parts of our country, still they get it. Somehow I have not seen commonly, but I am learning from my friends that from the rural area, particularly some parts of Maharashtra and other even states, I'm learning. And you know, sometimes there may be the presentation of hypertension. And great variety of the snake bite can present in this way. Why I say farmer family, suppose some house is in farm, and in this next day, and that how the presentation is known. And you know why I'm talking so much? If you are aware, give the anti-snake venom. Marvelous recovery, spontaneous, very good recovery. I'm learning from my friend, those who have treated even critical patients. So it's a very important learning session for us that always we should keep in mind. We are not sure. Maybe the GBS, but not necessarily always GBS. You should have the very wide spectrum of the thoughts. Of course, according to the presentation, story, findings, and you may go for confirmation from some investigations. But as a clinician, you should have a very wide spectrum of the conditions. And according to the given situation, circumstances, you know, sometimes circumstances will give the idea. And they say that don't try to find out the sting for the snake bite. You may not get it. If you get it, well and good. On the contrary, people say that you are having this convincing situation, snake bite, don't wait. Go for treatment of the anti-snake venom. Even the guideline is there. And you must be knowing that our national, even the government of India has prepared very good guideline for the snake bite management. Recently, you know that where is the center they have started for the snake venom? Anybody from, I will say, any from the screen if aware? There are only 2 centers in India. One is already there, second recently they have started. Anybody having any idea? Even it appeared in the newspapers. Yes, Dr. Pranshul say Trichur. I'm not sure whether, Dr. Pranshul, are you from Trichur? Please respond to my question. One center, I'm not sure. The second, recently they have started in Gujarat. And nearby Valsad.
Dharmapur.
Dharampur, exactly right. Yes, Ritesh, very good. I was not able to recollect the town, but that is the exact Dharampur. Very small village nearby Navsari and Valsad. And these are the, I will say, some forest areas. And they have located that different snakes are available. So from that snakes, they are preparing this anti-snake venom. So, you know, all the developments, we should be aware of it. And that helps us in the management of the patient. Anyway, I think before we go to the end of the story, let us see, Viram must have some investigations. Viram, you have investigations?
Sir, I have not attached the investigation to the
Very
PPT,
good.
sir,
Well, I will appreciate you. I like it because I am least interested in the investigations. I will say master clinician will say that this is my clinical diagnosis. Of course, investigations are for just confirmation. But Abhiram, how will you say it in the GBS? And anyway, how will you start the treatment? Suppose, or what investigations you should do? Let me know from you. Or even I will say Ritesh. Ritesh, what are the investigations for GBS?
Sir, nerve conduction studies
Okay.
and
Anything else? Yashwant, Kirti, anybody? Those are in the idea. Please always try to answer. Yes, come on.
Sir, CSF.
CSF, okay. What you are going to get in CSF, Kirti?
Sir, will get albuminocytological dissociation.
Okay, Abhiram has done and he said normal. What is your comment? Kirti, Abhiram is your colleague, am I right?
19.1.
Kirti, I will say for your colleague, always make the comment that he is wrong. That becomes a good competition for learning. Bandari sir, can you mute yourself? Sir, please. Hello, Bandari sir. Yes, Ritesh, anything else? I think CSF point of view, Abhiram, can you make the comment?
If the CS examination is done and it's come,
whether any other, I will say, the technical person can mute Alok Bandari sir. Probably he is not able to listen to us. Any technical person from the Zoom company, Zoom, I will say team. Yes, Alok Bandari, listen to us. Thank you, sir. Thank you. Yes, Abhiram, what you will get in CSF?
Sir, if the CSF examination in this case, if it comes up to be having no albuminocytologic dissociation, we have to think of viral infections like HIV, then sir, other viral infections.
But Abhiram, my resident did it and informed me that, sir, it is normal. But I said that no, it should not be normal.
Sir, initial, within the first week of the illness, there won't be any albuminocytologic dissociation.
So that's the thing. At what time you have done the CSF? Early, if you have done, may be normal, may not show the albumin cytology dissociation. Best, it may start after 72 hours or so, but best interpretation will be after 7 days. Why there is an albumin cytology dissociation, Abhiram, in GBS?
Sir, there is disruption of the blood-brain barrier.
Okay. So what happens? So what happens? You know this, you have the good, I will say, scoring, then examiner is going to ask you the very details. You know, there is the... Yes, please, come on. Always your turn is first. Abhiram, yes, you were speaking something, please carry on.
Sir, due to the breakage of the blood-brain barrier, the cells will move on to the serum. There won't be any pleocytosis in CSF.
Suppose if you are examiner, how I will take it, you know, that you are having some idea, but not the clarity. But I will say, okay, fine, he has some idea. What happens, you know, even in GBS, initially sometimes there will be the backache. That is due to the root pain. Am I right?
Yes, sir.
And that root pain is due to what? It is called as a radiculopathy.
Radiculopathy.
And that radiculopathy, that means, you know, the peripheral nerve root up to that, there is a sheath of the meningeal layers. These layers are disrupted, as you say, blood-brain barrier. And therefore, there is the easy, I will say, penetration of the protein, but not the cells in the CSF. And therefore, in the CSF, protein increases, but not cell, because there is no inflammation. Cellular reaction will be the inflammation. And there is a very classical point, and cells should not be more than 10. I think somebody has said probably 50, but probably not more than 10 cells. That is a very good point. When you are not sure regarding the GBS, these points are helping you. So that is number one. Second, suppose earliest if I want to confirm possibility of GBS, is there any test, even non-invasive? I don't want to go for CSF, or parents may not allow me.
Nerve conduction studies.
Before that, nerve conduction may not be the good test. Anybody? Kirti, Ritesh, Yashwant. Now I know some of the students. Next time I will know more, provided they are attending. Non-invasive, very sensitive, more reliable.
Sir, MRI, sir.
MRI of?
MRI spine, sir.
MRI spine. Good. You can do the MRI spine, and that will show some of the changes of inflammation. Earliest even. It is said that even once a disease starts, yes, you are expecting the MRI changes. So the recent test you should know, MRI, CSF, yes, now conduction velocity is the right answer. Anyway, suppose when you will suspect that it is probably not favoring GBS, what are the points? Are there some points from which you can suspect that not favoring GBS? Yes, classical clinical picture is there, but not convincing. From which points you will not be convinced? GBS. Anybody? Ritesh, any idea?
Asymmetrical involvement, sir.
Yes, asymmetrical involvement. Occasionally it can be in GBS, but asymmetrical not convincing to me. Very good point. Anything else?
Bladder bowel involvement.
Bladder bowel involvement, very good. From
Sir,
the beginning,
sensory involvement.
sensory involvement, it can be there. May not be. We know these are different varieties. One is the Aman, that is the exon variety, and another is the acute demyelinating polyneuropathy. In acute polyneuropathy, well, sensory can be involved.
Okay.
But presence of fever.
Yes.
Presence of fever does not convince me much. From the beginning, when the onset of the manifestation, the fever is also there. Then probably I may think transverse myelitis or something, but may not be the probably GBS. Okay, anything else?
Sir, early bladder involvement.
Yes, already he talked, but bladder involvement. Okay, then you know what are the bad predictors that you should find out. You will not be happy that this finding or this particular sign is not good for the recovery. I'm not interpreting, I will say not expecting good recovery. I'm expecting some problem or mentally I'll be prepared for some complication. So what are the points?
The autonomic instability and respiratory muscle involvement.
Very good, very good. Autonomous nervous system involvement. People have located that somehow ultimately problems, complication rate, even mortality is more with these patients. Particularly the sweating, tachycardia, hypertension, labile hypertension. Okay, anything else? Another point.
All four limbs involvement, quadriplegia.
Okay, that can happen.
Rapid progression.
Rapid progression is very important point. Within even few hours progression. Second thing, respiratory involvement, bulbar involvement.
Bulbar involvement.
They are not, I will say, helping much. Then you know obesity. Please remember obesity. Obesity is the very bad predictor for the good outcome. For any disease, more so with this. I have seen even one of the child, in spite of the mild presentation, deteriorated very fast, and obesity was the major issue. And I learned from one of the neurologists that obesity nowadays is very common, and that presence of obesity makes difference in the outcome. So I think there are some points. I may not be able to recollect every point, but I wanted to sensitize you that you should keep in mind. I would say last point we will touch and then we may end. Well, how will you manage treatment? What treatment you will offer? You confirm that yes, it is GBS.
Sir, we can give IVIG.
Okay, what dose? What dose?
Sir, 400 milligram per kg per day for the 5 days, a total of 2 grams, sir.
Okay. Now, any other regime is suggested?
Sir, 1 gram per
Yes.
1 gram per kg per day can also be given for 2 days.
For 2 days, yes. And people are favoring that probably this may be better regime than this one. Okay. Where the second dose of the immunoglobulin is required? And how will you decide? In other way, if I ask you, what is the refractory GBS?
Sir, if there is no improvement,
Yes.
the second dose is required, sir.
But when I will decide that there is no improvement, no response to the first dose of the IVIGG?
More than 8 weeks, sir. Then it comes CIDP.
Okay. I think it's a little bit long, but 4 to 6 weeks, yes, Ritesh. That's a good point. And second dose, even you may go. But some people say plasmapheresis. Which one is better?
The studies are showing that both of them are of equal value, sir.
Very good.
IVIG.
IVIG is better, sir.
Yeah, but once you have gone, suppose IVIGG, immediately don't go for the plasmapheresis because it will remove these immunoglobulins. Suppose by chance if it is that. Third point, I will say there are many points, very difficult to even discuss everything, but I will give some ideas. Is there any role of steroids?
No, sir.
No.
Okay, but some people have used at certain points. Which is the point? Bold statement is right. There is no role of steroids in management of GBS. Yes. But occasionally, some people use in some part of problem or complication of GBS. Which one?
Sir, in chronic inflammatory demyelinating type, there may be a role of steroids, sir.
Okay, Kirti, this much I don't know. Sorry. Anyway, what I mean to say, very limited role of the steroid. Usually people say, I think bold statement, if you make it right, no role of steroid. But, sometimes as already we were discussing radiculopathy, there is pain, swelling of this root pain. And that to decrease the swelling, some people use the steroids. Suppose persistent pain, back pain, due to this, you may give the short course of steroid, but not from the GBS point of view. Very good, I will say several points. And nowadays, GBS is increasing due to the various reasons. Post-COVID, many people say, mycoplasma following, some even influenza following some problems. So exactly difficult to say, but one thing is very certain that compared to recent past, we are getting more patients of GBS and different varieties. And GBS can be the full question in your theory also. So I think all the postgraduates should prepare it thoroughly, very thoroughly. I will say anybody is doing some history part, last 1 or 2 minutes, and then we'll end. What is the history of the GBS? Who was GBS? And how much this disease is, I will say, known to us? How much disease is old? Any idea? What is the another name of GBS? GBS, Guillain and Barre has snatched the name.
Sir, Landry's paralysis, sir.
Yes. That was the Landry's post-infective ascending polyneuritis. What we were taught was like that. He was the first person somewhere in probably 1850-60, I'm not sure, but that was the era when he suspected this type of the post-viral polyneuritis. Later on, Guillain and Barre, and one third person was there, but he was radiologist. Therefore, his name was dropped. And then the Guillain and Barre, probably this was somewhere in 1950 or so. So again, it's not that old disease for identification. Anyway, so many things are there. We'll have to keep in mind the time. Already we have crossed the time. So we'll end over here. Thank you very much. First, Abhiram, I think you have prepared the case very nicely. Or I will say tone of presentation was good. It indicates your confidence. And I'm sure that I want that every student please go for the multiple presentations. Then during exam, you don't have any hesitation. You are confident. And of course, I will say your mentor, probably Dr. Priyanka, she must have taken the lots of the pain to prepare you. Yes, Dr. Arif and even so many other my friends are there in the department. I also even give the compliment to them. For definitely, to know and to teach is a different thing. It's very difficult. And to even make the students to go for the presentation, to motivate them. But ultimately, I will say it's a good quality of the teacher, and we'll have to, all of us, it's a part of our duty. So certainly, I will say it is quite appreciable. And again, Nihal and Dr. Arif and even Dr. Trupti, I came to know that so many youngster people have come forward to arrange this whole show. I understand that what we discussed, but for there, all these people are taking they are making lot many efforts to approach somebody, to teacher, then to request them, they become the ready, then some students and good presentation. So many people are taking the pains. And of course, for all the things, ultimately the credit goes to our President, Madam Dr. Neelam Mohan, Dr. Ruchira, and the whole central team. You know how much they are, I will say, having the vision that preparing this type of program, putting on the national level, and so many, I will say, students are benefited. And even teachers like me, so many teachers. I'm getting sometimes the messages from my friends that you are discussing. I was having the cup of coffee, enjoying the coffee and listening to all of you, the students and your comments. So even some senior friends are also, and I request all of them that please come forward and your comments will be more, I will say, enriching the knowledge of all of us. So over to you, Dr. I will say Nihal or somebody from the team. And again, a word of, I will say, gratification and really thanks to our President, Dr. Neelam Mohan Madam and Dr. Ruchira and the whole central team. Thank you very much. Thanks a lot. Again, next Tuesday, we are going to meet at the same time, 6 to 8, with a new case, new team. And I requested all the students that whoever is present, your presence should be there, your video should be on, your voice should be there, your comments should be there, your questions should be there. And we'll take the help of so many teachers. Even suppose if I am not able to answer, somebody else will answer. But ultimately, all of us will learn. Thank you very much. And over to you, I will say the team from Nihal or anybody else from that team. Or Dr. Priyanka, you can take over it. Thank you very much.
Thank you, sir.
And good night.
Thank you, sir, for this.
Yes, Dr. Arif is there. Dr. Arif, thank you very much. Please take it over.
Thank you, sir, for the nice, enriching session. Even I am learning so much things from you, sir. And it is our privilege that you are with us and to guide us and to guide our PGs also. So, sir, we are very thankful. And we are thankful to Dr. Abhiram and Dr. Priyanka Patel from the BJ Medical College, who has taken the pain and that prepared this case on very short notice. So we are thankful to them. So with this, we can conclude, sir.
Yeah, I think Dr. Arif, before that, let me acknowledge, I will say, presence of some of the most senior people and silently just they are, I will say, listening to us. Dr. Alok Bhandari, all of you know, I will say, great academician from Delhi and contributing a lot in IAP, all of us know. Even Dr. Ghansham, I know that he is also the senior person. Dr. Anand Keshwan was there. And he is regularly, I will say, contributing in our PG programs. Some of the even teachers are there. I may not be able to. Dr. Trupti, I know that she is there, probably from Aurangabad. I'm not sure whether she is able to recollect, but I have met her, I remember, in the Aurangabad. And so many teachers. I request them that please, all of you can continue to remain present, sparing some of your time from the busy, so many other activities and practice. But ultimately, I think it will be useful to us and contribution to the students and IAP as a whole. Thank you very much. And we end over here. And next Tuesday, again at 6 o'clock, we'll be there with some new case. Thank you and good night. Good night, everybody.
Thank you, sir. Thank you for your valuable advice.
So, like I'm sharing a one WhatsApp group link. So that you can share those links to your concerned groups and so that we have more PGs who can benefit from this online lecture. So I'm putting in this chat box and we'll be sharing soon also. So like you can share this link to the your colleagues and the other members from the different medical colleges. Dr. Bhandari sir.
Yes, please, yes.
Sir, would you like to say something?
Well, I will just like to say that IAP has taken under the leadership of Madam President Dr. Neelam Mohan to involve every section of pediatricians into IAP activities. So I will request that all those younger budding pediatricians who have taken up or decided to take pediatrics as a career should immediately join IAP and become a member of IAP so that you will directly get information on academic updates and all the various activities in which IAP is organizing or giving it for the benefit of our younger or all types of pediatricians at various levels. And then as the next step, at all medical colleges or hospital levels, we'll involve all the postgraduates into a big cohort of all young postgraduates. And there are so many other academic events happening all across the country. So the digital medium is a very strong medium. Through our Digi app, you can access the knowledge at your free will. So that's a great option. So please go ahead and become members of IAP and strengthen our PG Young Cell and Yuva Brigade. Thank you, please. Thank you.
Thank you, sir.